Thank you everyone for inviting me here today. I'm Emma Hallam. I'm a consultant therapeutic radiographer and I run a late effects service back up in Nottingham. I first met Emma when you saw me speaking at one of the other conferences. And I have to say, it's just a privilege to be here really. I was saying to Francis earlier, every single patient that I see, I take something away from. I learn something about an effect that's affecting them in a way that maybe I might not have thought about. So I feel I can be as close as experiencing what you're going through without actually experiencing it, and I've been running this service now for 10 years. Okay, next slide please. So I probably don't need to tell any of you in this room that life is different after cancer treatment. Many patients will go on and have a most amazing life, they're going to live the best life, eat well, exercise, but for others they'll have consequences from their treatment that they'll experience daily for the rest of their lives. Macmillan did a lot of work back in 2013 when we set our service up, and said that cancer and its treatment often leaves a gruelling physical and mental legacy for many years afterwards. We also know that there are 4 million people living with cancer, and that means that you've been through your cancer treatment and are living afterwards. By 2030 there'll be 4 million. So you can see how services such as mine and other services that are support services within the NHS are going to become more and more saturated. We also know that 1 in 4 cancer patients will have one or more treatment related effects that affects their quality of life. And this was the statement that really made me think when we set up our service. Of 2 million patients that were surveyed, 71% of those patients who'd finished 10 years ago or more had experienced a physical health problem in the last 12 months that was directly related to their cancer treatment. So in terms of the radiographer who used to deliver that treatment, we used to go, oh, a couple of weeks and everything will settle down. That is certainly not the case. Bit more about the head and neck side of it. A study in 2019 found that 78% had one late effect. That was 162 patients, 44% dry mouth, 28 skin changes, 22 fibrosis and 14 dental decay. So the one thing I keep banging on about now, it's no longer acceptable to us to purely focus on acute toxicity, so the effects you get on treatment and survival rates. We need to be thinking about we're curing people, but at what cost? Next slide please. So these are the acute effects of radiotherapy that are commonly seen. So there you've got the problems in the mouth there, so that's the oral mucositis. And sorry, I will just say I'm focusing on head and neck today, but I'm very aware that there's lots of patients who have treatment elsewhere, and I'm very happy to have conversations about that. The service I do is from head to toe, but for today we're concentrating on head and neck. So that's oral mucositis, that's that inflammation, that soreness that you get when you're on treatment, and then this is our radiotherapy skin reaction. I'm just going to correct what we've said about burns today. It's not a burn, it's an inflammatory response, and that's really important to understand that, especially for health professionals who try and treat it like a burn. So it's an inflammatory response that then settles down after you finish your treatment, usually around 6 weeks. Okay, next slide please. But all of them settle down. Then we start to move on to the arena of late effects. So what is a late effect? Well, a late effect is a health problem that doesn't, or a side effect that doesn't settle when you get to 6 months out of treatment, or a health problem that can develop many months, many years, many decades after you've had that radiotherapy treatment. It's often misdiagnosed and very much under-recognised by many health professionals, and many of the patients who come to see me will say, I've been telling people about this for years, but nobody's giving me any help for it. It's often progressive and can have a real detrimental effect on quality of life. We also know that those patients who have lots of treatment, so surgery and radiotherapy, or surgery, chemo and radiotherapy, and not only have more acute symptoms, but they're also more at risk of more increased late effects. So when somebody mentioned this, I was very impressed when you mentioned it, the treatment that keeps on giving, absolutely. There's papers that say that. They actually call it the gift that keeps on giving. I've taken it and put the treatment that keeps on giving. And that's due to this radiation-induced fibrosis. So this is a progressive fibrotic sclerosis with varying clinical symptoms. So it affects the exact part of the body that you've had that radiotherapy treatment in. It stiffens the connective tissue, compresses peripheral nerve tracts, contributing to diminished strength, flexibility and loss of function in that treatment area. This damage results in a shortening of tissue, so you get that real tightening, muscle atrophy, contraction, brittle bones, lymphedema, nerve and vascular damage. We also know that further fibrosis as it progresses will lead to more and more functional impairment. It's difficult to diagnose and often, like I say, misdiagnosed, and we know that management can be really complex. And we also know that more damage can be done to irradiated tissues by inappropriate investigations and sometimes unnecessary treatment. Next slide. So, like I said, most patients will have no problems whatsoever after they, might get a bit of tightening, doesn't really bother them. But for other patients, the effects of the radiotherapy will continue and have more and more of an impact on their life. It might affect their normal functioning, so they might have to have lots of water when they're having a drink, but it can be life-threatening. If your swallow is so compromised that then you are aspirating and you get pneumonia, it can cause aspiration pneumonia in hospital, and that can be life-threatening. So there's a number of things that we do need to take these things very seriously about. A lot of times we find though it's when we get called in when the patients are really poorly, well, when did that start? Why are we not intervening with this a lot earlier? Next slide. So the next slide should show, if I can remember, this is what your information booklets say. Well, no, my service was funded by Macmillan. I'm very grateful to them. This is what their Macmillan booklets say about the effects of head and neck radiotherapy. Okay, so 2, 4, 7 things there. Okay, very general, very wishy-washy. I have to say, if you had radiotherapy today now, the Royal College of Radiologists have done some new consent forms, and they're in a lot more detail with a lot more risk and percentages to show you what you may get. There was a study in America of a support group of about 15, 16 patients who'd all had chemoradiotherapy, and this next slide shows you how many problems they had that was directly related to their treatment. 62 problems that was directly related to their treatment. That I'm not saying they weren't being managed, but so it just shows you going from 7 things on there. That was what from this, it was from the MD Anderson. Okay, next slide, please. Oh, I need to jet back. Yeah, okay. So what I'm going to talk today is about the radiotherapy-related effects that I commonly see in clinic. Okay, so the first one is a dry mouth. And I talk constantly to health professionals about we must never underestimate what a dry mouth means to a patient. I've had it where clinicians have said, well, we're not going to tell them about that because there's nothing we can do about it. But it is so important that we are telling patients that life is going to be different afterwards. Living with a dry mouth is a difference between not just being able to swallow your food down and talk like I am today. I'm very much drying up as we speak. But it's a difference between being able to kiss your partner. We have patients who no longer sleep in the same bed as their partner because their mouth is so dry that their breath smells so much. And this doesn't get any better. Obviously, problems with swallowing, it might be due to the radiotherapy itself. What you have to remember is that you need your tongue to be able to push your food to the back of your pharynx there, and then your pharynx squeezes your food down. If that's all fibrosed up, that isn't working. So it can start off very slight, but over time, this can become quite rigid. Dysphonia, so when you get problems with your speech, you might not be able to vocalise as much anymore. That again can be due to dry mouth, like I said. And all of this can lead to weight loss, malnutrition. Okay. Tooth decay, and I know Francis is going to talk about this a lot more, but I will often see patients who are very much wearing the masks, like we said, and they love wearing masks because their teeth are black and they are crumbling, and there is nothing we can do about it because the last thing you want to do is take any teeth out when you've had radiotherapy because of the risk of osteoradionecrosis. Trismus is something that we see is really common, and that's when we fibrose up the TMJ here, and again it might start, oh, when I yawn it just hurts, but over time this will happen if the right exercises and the right treatments are not put in place. And I get patients come to my clinic who go, well, 3 years ago I was fine and now I can only go through a straw. Well, why wasn't there any support there? And I'll tell you why, because a lot of patients are out of follow-up, but by the time a lot of this can start and get really significant. So the fibrosis causes stiffness in the jaw, neck and shoulders, and of course we've heard about it all today, hearing loss. It's not just about the hearing loss, it's that constant tinnitus that you get. You know, I've had people who've had to give up their jobs because they cannot concentrate on that, but also the balance issues that this can cause as well. So that's why we find patients, we actually sometimes get brought in because the patient's been constantly falling and they go, well, I don't know what's up with them. Well, it's because they've got balance issues from the hearing loss and the damage that we've caused there. Lymphedema is really significant and we need to be treating this at a much earlier time point. I specialise in head and neck lymphedema now, making sure that any sign of edema, we address it there and then. What happens is you go for your 3-month scan after you finish your radiotherapy treatment and your surgeon or your oncologist will go, oh, it's just a bit of lymphedema, it'll settle. And it might settle, but if it doesn't, it'll harden. Then if you get radiation-induced fibrosis, you can see why, years down the line, your side effects are really significant. And it's something you can do something about. Fatigue I'm going to come on to again. Peripheral neuropathy, so tingling in your hands and feet due to some of the nerve damage, or it might be just if you've had chemotherapy agents as well. And these pain, I mean, you talked about pain, Emma. I rack on about pain all the time. and I'm going to talk about pain in a minute, but the painful neck spasms that you can get. So I've had patients who will literally be like this, and people think I'm having a stroke. I had one chap who said, they think I'm drunk, Emma. I don't go out now because if I have one of these episodes, people think I'm drunk and they're just stepping over me in the street, but it's so debilitating when these spasms take hold. And thyroid issues, absolutely. So that just pictures there just shows, this is classically what a radiotherapy head and neck would look like. They call it a fibrotic woody neck. And this is skin changes. So little tiny blood vessels that come to the surface and are broken. That's called telangiectasia. That's quite common to be seen from the radiotherapy. Next slide. So alarming everybody now. These are the ones that I have seen in clinic but are less common. So really quite rare. And the first one is this chronic radiation dermatitis. So this is where patient's skin has been absolutely fine for many years, and then they start to get this breakdown. They've always usually got fibrosis there that they can feel, so this stiffening, but then the skin changes, and it can lead to necrotic ulcers as well, where the skin actually breaks down. Nerve damage, and this osteoradionecrosis of the jaw. There's actually only up to 7% of patients that get osteoradionecrosis actually. But again, if you get it, it can be really quite debilitating. Obviously, you can get it in other bones, you can get it in any bones. We have had an osteoradionecrosis of the spine before. And then carotid artery patencies. This is where you'll get fibrosis in your carotid artery due to that radiotherapy. And often we send people for scans because nobody's thinking about this when they've had the treatment. It's not something that we screen for. Cervical dystonia, this is where you get this head drop. Now, obviously, usually you've had to have had both sides of the neck treated. But this is where patients cannot physically hold their heads up themselves. So they're walking around like this, and if they were talking to you, they'd have to hold their head up themselves. Burning tongue syndrome and recurrent oral thrush go hand in hand, really, in my opinion. This is where your tongue constantly feels like it's on fire. Lots of health professionals think it's because of that dry mouth that you've got. Well, actually, yes, the dry mouth is because of that, but it's actually due to the nerve damage. So I was finding that I was putting patients on some neuropathic pain medication for their burning tongue, and the speech and language therapists kept taking them off it because that was making the mouth drier. But these patients are never going to get back swallowing unless we get on top of the pain. Then put in some recurrent oral thrush because your mouth's so dry as well. You can see how you've got this vicious circle, and these consequences of treatment are all compacting each other. And of course, we always have to be aware of secondary cancers. It's usually in the form of a skin cancer. Okay, next slide, please. So, what's really important is these are common effects of all cancer treatments, I would say, whether it be surgery, chemo or radiotherapy. And the first one there is pain. 1 in 3 cancer patients will have chronic pain after treatment, and it can persist for many years and affect your daily functioning. We often know that if left untreated and it's really severe, it can lead to unnecessary hospital admissions. But a lot of the time when I'm talking to patients about pain, it's about thinking about that psychological impact of pain. And we have to actually work on that and turning your pain receptors down, because what we know is that your brain's telling you that, gosh, when I had that, that's when I had my diagnosis. So everything is heightened, so we have to work very much on turning those receptors down. Fatigue. Most commonly reported symptom up to 10 years out of treatment for all cancer patients. Up to 35% will have really chronic fatigue, where they literally cannot get out of bed, cannot manage to function daily, and it can have this massive impact on your social life. What we need to think about is the impact of the psychological challenges. No patient comes with just one treatment. If I do a holistic needs assessment, they fill about 10 in. And you can't deal with one without dealing with the other because they all impact each other. We see a number of patients who have this survivor's guilt, who will say to me, I should feel lucky to be alive, I should feel grateful to be alive, but actually I don't because of how I've been left. And that is really upsetting for these patients to experience. Often they'll stop talking to their family and friends about it because they say, well, you know, my family and friends are saying, aren't you doing well? Oh, you're ever so positive. When inside they're not feeling like that. So it's really important that we're acknowledging that, because all of these things will make any physical late effect from treatment much, much worse. Obviously, we need to think about relationship changes, not just about body image concerns, but the changes to how we feel about how we are and wanting to have that intimacy with our partners. So we actually run a psychosexual service as part of our late effect service, really making sure that we're encompassing all of that. And a lot of that also involves the partner as well. Obviously, some patients do go back to work, and we've heard some great stories today, and that's fantastic, but lots of patients will have different jobs afterwards. May never get back to work or may never get back to their studies. And we really need to be thinking about the reduced cognitive function. It's not just about whether you've had chemotherapy and you've got this chemo brain, But the impact of that fatigue, the impact of that pain, how is that affecting us cognitively? I've got one lady who said, my husband won't let me make beans on toast anymore. All my food is left for me because I can't remember to turn the gas off. And she just feels like her whole life's been taken away from her, and that's because she feels so tired and she's got this pain. And actually you could say that's really the only effects that she's got, but actually that's massive on how she's living from day to day. So our service very much looks at psychological, emotional, financial and the spiritual side, as well as all the physical effects. Okay, so the next thing to think about that is just about this lymphedema that I said, but the importance really is about early identification with any of these things. We know that for lymphedema, it's reversible, but if you leave it untreated, it leads to this much more fibrotic changes and resistance therapies. Up to 90% of patients will have a degree of lymphedema after treatment. Do we do anything about this? No. But yet only 7% will have osteoradial necrosis, and we take lots of patients' teeth out. I don't understand it. I can't understand the... I know osteonecrosis is horrendous if you get it, but we know that early treatment and educating patients really could prevent late-stage lymphedema, reduce associated burdens and improve quality of life. And this is something that I'm doing in Nottingham, is trying to identify it early, give some strategies to manage the radiation-induced fibrosis to see if we can stop the severity of all these late effects. Next slide, please. So my service is a bespoke service initially funded by Macmillan back in 2013, providing advice and support for any patient who's had chemotherapy and or radiotherapy and experiencing a physical and or psychological effect. I was the first therapeutic radiographer to set this service up. In fact, it was the first one of its kind within the UK. And we provide highly specialised care for patients. You do have to live in Nottingham or Nottinghamshire. However, I never turn anybody away, I'll be very honest, as Emma knows. Whenever I talk, I get a whole list of people and I always end up signposting and things like that because that's really important. But there's loads of services setting up now, I will admit, on the back of us. We're a fully holistic service addressing quality of life needs, and we offer appointments via face-to-face, video or telephone. Obviously, if I need to examine you, you'd have to come in. But we work collaboratively across traditional boundaries, and that means that I am getting other health professionals who we need in our clinic, and if they can't be in our clinic, then I will get that skill needed, and that's where I've come now to deal with all the early lymphedema. So obviously you've got severe lymphedema, they absolutely go onto the lymphedema team, but it was quickly recognised that by working together and covering other people, other services, when you haven't got them services there, can be so beneficial to that patient. Most of our late effects are now dealt with in-house, but obviously with complex needs we do refer on. Next slide, please. So I just wanted to show you the number of referrals. You can see year on year, look how many patients we're now seeing. I'm very proud of this, but actually the number of patients who've had to refer on to other services has remained pretty stagnant. So we're a really good cost-saving initiative for the NHS. This is how many patients seen by area. Look how many head and necks there are. Breast was only 320, 700 head and necks that we've seen. And that's because they have the highest unmet need after treatment. And what we now do in Nottingham is we screen for patients for 10 years after treatment with head and neck patients. So we've seen over 1,600. The longest time from treatment to referral was 37 years, and I picked out the salivary gland ones. And the longest salivary gland patient out of treatment was 14 years when they got referred to our service. And the problems that he was having was this left neck pain due to the fibrosis, lymphedema, tinnitus and neck spasms, and he was getting no support whatsoever for it. It was just being documented in the notes, and it just said, that'll be the radiotherapy, and that's all that was happening. Next slide, please. So as I said, we now follow up all our head and neck patients. So we do it by a patient-reported outcome measure, so a questionnaire that we've designed that basically screens for every single late effect you could possibly have. And patients fill it in. They do it at 4 months, 1 year, and then it is actually now going to be every other year because I'm getting saturated with patients, as you can imagine. But patients tell me they feel safe, they feel like they've got this safety that we know what we're looking for. And it also enables me to track patients over time, so I can see, well, they weren't reporting that a year ago, but now they're starting to, and next year it's worse kind of thing. So just show you the array of concerns that there are there. No surprise, problems with throat and neck. Lymphedema, fibrosis, swallowing, and emotional and social was the main concerns. And then the next slide. So basically the essence of a late effects service really is about listening to a patient. Some patients will not have spoke to anybody for a number of years, like I said, about what they really feel, how they've been left after treatment. If you can listen to a patient, help them to understand why they have been left like they have. So get their treatment scans out, show them where the high dose rate was. Tell them about this is how radiotherapy works, this is the nature of radiation-induced fibrosis. You can help to lead towards acceptance of where they are now. Throw some management strategies in there, and this is what we're doing to really provide this self-supporting management. We are changing lives around. So, I thought might be helpful was to tell you how you can actually do a bit of self-supporting management and what you can do to help yourselves. So the first thing is understand about late effects. So understand you have to be the expert in your own treatment, especially if you're going to see a new health professional who might never have come across a patient who's had radiotherapy before, especially if you're going for a different condition. And notice and report any change. Now I know with the nature of salivary gland, absolutely, you're asking for scans all the time, so you're going to be doing that anyway. But don't just do it about new lumps and bumps. It needs to be about new tightening, anything that's different for you. Because this early identification is really key on trying to delay the progressiveness of these late effects. Follow any given exercises or plans that you're given during treatment, and I would continue them for life. Adopting good oral hygiene and dental care, and Francis is going to talk about that, and manage your dry mouth, because this can really help with any dental problems. Maintaining a good nutrition, so a good healthy weight is good, and also hydration is very important, and follow skincare advice, and that is that you should be using a moisturiser a couple of times a day. It doesn't matter what that moisturiser is, and there is no evidence to any cream that is better than any other, but making sure you're getting that hydration in there, because the more hydrated your skin is, the more supple it is, the more chance you've got, if you have got a build-up of lymphedema, to be moving around. And we know that engaging in physical activity is really important. There's a recent study out this week, and I've not read it properly, that said it's the most single important thing you can do after your cancer treatment to prevent longer term problems from your treatment. I've took a picture of it if anyone wants to see that. So what I want to focus on now is top tips on living with a dry mouth. I don't recommend products. I could prescribe you something, but I don't. Because often what happens is once you get back out into the community, your GP won't prescribe them. They're expensive if you buy them yourself, and half the time they don't work. So we like to give patients top tips on what they can do. And a lot of these are what I found from visiting support groups, trawling the world really as to what other head and neck patients are using. So if you want to use sugarless gum, you need to make sure it contains xylitol, because that's what helps to stimulate saliva. We also know that certainly there's an enzyme within certain fruits, so certainly in terms of pineapple, that can really help with sometimes them secretions and the saliva, the thick secretions that you can get after treatment. We know that mouthwashes can be really drying, even if you go for the ones that aren't alcohol-based, that mint flavour. So the best thing you can do is use half a teaspoon of bicarbonate of soda and half a teaspoon of salt in warm water. My top tip is actually making sure that when you're feeling that your mouth is dry, don't drink water, because all you do then is wash any natural saliva you've got. Get a little spray bottle, fill it with water, and put a tablespoon of olive oil in there, mix it up and just have a spray. If you haven't got that and you need to take water, just do it so you wet your lips, because wetting your lips then adds to that saliva. Keeping your lips nice and moisturised, and we also know that just moistening your mouth, particularly at night with either olive oil, I say coconut oil now because I think it's a bit nicer, and Aldi do a very cheap one, so don't go pay for a fancy one. Half a teaspoon, and kind of try and suck it around your mouth. It puts a bit of that lipid barrier on to get you through the night. Obviously, avoiding chocolate, pastry, caffeine, alcohol and tobacco. That isn't a must. I had a patient shouting at me the other day, "You've ruined my life, you've told me not to eat chocolate." I'm not saying that. What I'm saying is you need to be aware that these things will be drier. They have a drying effect on your mouth. They would for me. Particularly if you're struggling at night time, a humidifier on a cool setting can help. And again, good dental hygiene and regular checkups. Next slide, please. So in terms of swallowing, if you are given any swallowing exercises, it's really important that you follow these. It's really hard, I think, sometimes when you're on treatment to continue with these swallowing exercises, because it's probably the last thing you want to do, but it is so important. The thing with your swallow is if you don't use it, you will lose it. It's a muscle like anything else in the body. And if you start to notice any changes with your swallow, so whether that be that things are just sticking a bit, or you're coughing a bit, or you're tending to find that things coming up and down your nose, report it. If you haven't got a speech and language therapist, go back to where you had your treatment and make sure that they are aware of that. There are also some community speech and language swallow teams now as well. There's quite a few of them in London, so you need to be seen so that you can have your swallow assessed. Next slide, sorry. I keep forgetting that bit, don't I? Okay, so exercise and positioning is so important. We've designed an exercise program. It's called our home exercise program, which was put together by myself, the physio team, the lymphedema and the swallowing team, because we wanted one program that patients could follow, because what we find is you get given then 5 exercises from your lymphedema team, then from a physio, then from a swallowing therapist, and nobody does any of them because they're just like, whoa, constant reminder of what cancer I've been through in the treatment. So we've come up with something, but what we do tell patients is you have to follow this for life. It's not just to do for the next 6 months, it's for life, because what we're trying to do is prevent those fibrotic bonds from forming and maintaining function. So if you are given any, do them, but if you haven't, you can find things on the internet like this. So there's this yoga, facial yoga is fantastic. Chewing gum. Making sure that when you sat down that your posture and gait is good and no slouching, because if you've got a little bit of lymphedema, and we certainly saw during COVID how lymphedema rates went through the roof, because everyone was at home either watching TV like this or sat on Teams, so we were getting lots and lots of this facial edema. And again, if you're sleeping, you may need to sleep upright or in a reclining position, because at night we know that lymphedema collects because you've not got that drainage with gravity. Next slide. If you did want to have a look at lymphatic drainage, obviously, if you can get to see a lymphedema specialist, if you notice you've got any swelling, that's fantastic. But for some areas, they may not have a service, or they may not deem you significant enough. You could have a look on the internet, and there is lots of information there. It's all about maintaining good skin, like I said, good skin care, all about movement, but also some of this drainage combined with breathing exercise. It's very easy to do. You can buy rollers that are quite good to help with that as well. And I've put these, and they'll all be available on the website, but Cancer Rehab PT has got a fantastic website about fibrosis and lymphedema. I think she's Australian or New Zealand. She's a physiotherapist. She's on Instagram. She's really good videos to follow there. And the British Lymphedema Society and the Lymphedema Support Network can be really helpful. They've got lots of patient guides on there for you. Next slide, please. So where can you access support? Well, first of all, I'd say a late effects service. And like I said, there's about 30 of these up and down the country now. They're not all doing head and neck. Most of them start on pelvic, if I'm honest, but they are growing. So I would always contact where you had treatment if you feel you've got any late effects from your treatment. And of course, Maggie's Centre are quite good at signposting as well. But go to your GP, ask for a physio referral if you feel that your neck's getting a bit stiff. And again, same for lymphedema. Obviously, we've got all the support charities there. In particular, I want to mention there is the Swallows charity. They will send you a box of dry mouth products if you want to try them, but you do have to buy them after you've tried them. But I mean, not the box, obviously, but if you like it to continue, you'd have to buy, but that is also great. I've mentioned about the lymphedema stuff. Joe Devine is really good for sexual health. So when I say sexual health, I'm not talking about keeping yourself healthy sexually, but about if you're having problems with your sexual health and the ability to, whether it be intimacy with yourself or with a partner. But Joe Devine is actually a nurse who set up this website, and she's got lots of blogs on there. It is a lot around breast cancer patients, but it's for all patients. That's a really good site that we use. Trekstock is a cancer support charity for patients who are treated in their 20s and 30s. And they do a lot around exercise and support in patients with how life is different. And Move Against Cancer is a charity that promotes exercise after you've had cancer treatment, and they've got some really good videos on there, and I've done a whole series of late effects webinars on there, but you don't need to watch that because you watched me today. But it's more about, you can have these chair-based exercises, and they also link in with the park runs as well, and once a month is a 5k your way that you can access. Okay. So things to be mindful of. I don't want to have frightened anybody today, and I'm well aware that, lots of people, like I say, will get a varying degree of these late effects and some won't bother. What's really important is we're thinking about that we all go through this stuff, but our experiences will all be different. And I just love this because everyone thinks it's the little dog that's really bothered by the mud, but actually it isn't, it's the big dog. So it's just to say we all go through the same stuff differently, but it depends on who you ask.